Great, thank you. Thanks for inviting me to do this talk. I remember being a pre-med and I used to go and attend mostly in person then, right? Of course, a lot of these types of talks. And so I'm happy to be able to share my experience and help anyone out on their journey. So I thought I'd talk a little bit about my journey to medicine, why it is that I chose to even go into medicine, which is obviously something that you guys must all be thinking about constantly to sort of navigate what to do with your careers and your future. So I've got an image here of a father and his daughter. So that for me was a big part of my growing up. My father was a family physician, and so he would have me attend some house calls with him. And so I really got a good sort of inside scoop on as to what it means to be a physician. I really looked up to the way that he was able to impact his patients and their families. I liked that sort of people connection that was possible as a physician. It's a very intimate kind of a impact you can have. I also loved sort of later on, I realized I did really like science and the idea of the way that more knowledge is changing medicine. It's a growing field, and I love the idea of being a part of something where we can learn new ways of treating patients. And I think that was a big part of why I then did pursue academia, which I will talk a little bit more about. So what is sort of what did I do in my undergrad? And what did I do sort of like, beef up my resume, you could say, to try to be a good candidate to get into medical school. So I did a undergraduate Bachelor of Health Sciences degree at McMaster University, which is in Hamilton. And it was a 3-year, it was a 3 or 4 year degree. I did 3 years. And during those 3 years, I was doing a lot of other additional things. I knew that research experience would be good for a number of reasons. One, it would give me more exposure myself to know what it really is like to do research in medicine, to help me decide if I liked that for myself. And also I also knew that it was quite competitive to get into medical school. And so the more diverse background experiences you have, the more appealing it makes you as a candidate. So I did, I did get hired in the only laboratory that would take me as a second-year undergrad student. And I did some biology research with mice, which forced me to face my fear. I did some hospital clinical experiences in different areas, pediatrics and geriatrics and cardiology. And then I also did some research, which was purely voluntary. And I was able to present a poster presentation at a meeting with that. I was also involved in a bunch of committees, including the Health and Science Society at McMaster. I was on the executive committee for that. And then I was also wanted to do something that wasn't directly focused on medicine, something that I was maybe more passionate about. And so I was involved with Amnesty International, and for 2 of my years, I was president of the one of the chapters there. And then I also did some extracurricular, and I think that was really for me a saving grace, because it allowed me to have some fun. So I was doing dance, including some dance competitions and traveling. And I think that without that, it would be hard to excel in the academics, because it can really get feel like really intense and not really that fun. So now a little bit about medical oncology more specifically. So how do you become a medical oncologist? So this slide highlights what it is that I did, which is the mandatory steps that have to be taken to become a medical oncologist. So I went to medical school at McMaster University in Hamilton from 2004 to 2007. Most medical schools are 4 years. This is one out of 2 in Canada that are actually 3 years. Then I did a 3-year residency in internal medicine. And that was in the University of Ottawa, which is the capital of Canada. And after that, there is another application similar to doing your initial residency application, and it's a CARMS match to do a subspecialty. And so that was medical oncology, which I did at the University of Toronto. And that's a 2-year residency slash fellowship. It's kind of considered to be a fellowship. But at that point, as a medical oncologist, you can decide to go ahead and start a career in a community hospital as a community oncologist, or you can decide to pursue further academics and then try to pursue a career in an academic center. So I was quite inclined to academia at the time. And so I did do a breast cancer fellowship, and it's quite an extensive application. And you do try to get funding from various organizations. So I did get a scholarship from the Canadian Breast Cancer Foundation, and they gave quite a large lump sum of money to support my fellowship and also to actually run my own clinical trial, which was very cool. I was able to be the principal investigator in a randomized trial, which had 100 breast cancer patients in it. It was really a very cool experience. At the same time, I did a master's in epidemiology, which is pretty much becoming a standard requirement if you want to pursue academic medical oncology. So that being said, after completing all of that and having everything sort of checked out, lined up to have an academic career, I realized that I didn't feel like it was the right fit. I wasn't feeling like it was where I really felt, there was probably some bureaucracy in academia, and I didn't think that was a good fit for me. So I, at that point, pursued a job in a community hospital to see if I would like that, and I absolutely loved it. So I've been at this community hospital in Toronto since 2017, and I absolutely love it. So as a community oncologist, really you're just treating patients, and you have less responsibility in terms of meeting academic requirements in terms of publications and presentations. So what is a medical oncologist? So it's actually a fairly new branch of internal medicine. It really got created around the 1960s or so. Prior to that, there was no such thing as medical oncology. It was more linked in sort of with just internal medicine. And so it's a branch of internal medicine dealing with malignancy, so cancer, specifically solid tumors. So that includes really all the organs. So breast cancer, colon cancer, lung cancer, prostate cancer, really all of the cancers other than the malignant hematology cancers. So those are the ones that deal with blood, bone marrow, and lymph nodes. So those are categorized separately as malignant hematology. Now, in some places, in some hospitals, there is just oncology. And so the oncologist may treat both solid tumors and malignant hematology. But with the vast advancements that are being made in terms of treatment options within each area of oncology, really these two are separating quite a bit. And most hospitals now have separate medical oncologists and malignant hematologists. As a medical oncologist, we are one of the cancer doctors. So we work closely with the other cancer doctors when we treat a particular patient. We work along with a surgical oncologist whose job is to really surgically remove the tumor, and then the radiation oncologist whose job is to use radiation and target it towards the tumor and try to treat it in that way. So this is a slide which shows that cancer prior to the 1900s was something purely treated with surgically. So the surgeons would just cut it out, and that was about it. Then in the early 1900s, that's when radiation became known to be an option for treating cancer. And then it was really in World War II that, interestingly, some experiments with some like Navy officers who were exposed to nitrogen mustard, it was found that it was treating lymphoma. So really it was in the World War II is when the whole area of systemic treatment of tumors even came about as a field of medicine. So traditionally, chemotherapy was the way that a medical oncologist would treat a cancer. So it would be sort of a traditional intravenous chemotherapy that would kill the cancer. But in the last 20 years, there's been a huge emergence of new therapies. And the rate at which they're now coming out is very, very fast. We've got immunotherapy, we've got monoclonal antibodies, tyrosine kinase inhibitors, and really a lot of new medications coming out every single year. So this is a diagram which shows sort of what I just mentioned, which is that in the early 1900s until about the 1950s and 1960s, really it was early ages of learning about systemic chemotherapy and how it can kill cancer cells, mostly lymphomas. But then chemotherapy became more widely used in the 1970s. It became quite standard in the 1980s and 90s. And then it was sort of in 1997, the first monoclonal antibody was approved. And then the tyrosine kinase inhibitors came out 2005. Around 2015 is when the immunotherapy has really started to become widely standardized and used. And so you could see that there's been a big growth in medical oncology. So immunotherapy, I thought I would just touch on it briefly without going into too much detail, but it is a really exciting new area, new as in it's been studied well over the last 10 years and been implemented as a standard therapy for the last 5 years. And it's very cool way of using the body's own immune system to really fight the cancer cells. And so it's pretty exciting from a scientific point of view for people that are interested in being in an area that's really growing and has a lot of new treatment options that are coming very quickly. I think medical oncology could be appealing. Another area which is really blown up is next generation sequencing, the NGS. So now we're able to use technology to really take a very close look and sequence the genome of the tumor or of the patient. And we can see where there's been abnormalities, mutations in their genome, which may be targeted then to treat the cancer. And so there's really just really like hundreds of different possible mutations or thousands. And so now there's, along with that, thousands of possible new drugs that are coming out. And so with this, medical oncology is becoming a very highly targeted and personalized type of a treatment field where really it's I think this is unique to medical oncology in our ability to really get to a very grainy, very molecular level in terms of how we're treating patients. So I thought I'd talk a little bit about what it's like to be a medical oncologist and what that means in terms of what does work look like for a medical oncologist. I think it's a really good it's a really nice spread between different components of a physician. For example, outpatient clinical work is usually a very big part of a medical oncologist, and we have to usually work in a hospital setting of some sort because we work with a team. We need to have our nurses and a chemotherapy suite where we can administer a lot of these medications. So it's not really a small private practice that you can open up like you can in many other areas. It's really that you need a big team to work with when you are a medical oncologist. Pharmacists are a very big part of it as well. And there's also a social worker, there's also a dietitian. And so really medical oncology is working with a team on a day-to-day basis. An outpatient is a big component. We also, of course, have to do some inpatient care because our patients can be very, very sick. And you can imagine they can be very sick from either the treatment that they're undergoing or really from their cancer. So we do have some inpatient responsibilities. On call as a medical oncologist is not too cumbersome at all. Many hospitals that I'm aware of, there's not too many sort of emergencies where the medical oncologist is called in at late hours. And if a cancer patient is admitted to the hospital, then usually in the hospitals that I'm most aware of, internal medicine or the hospitalists can often admit the patients, and then it can be dealt with by the medical oncologist the next day. So on-call is usually can be busy during the day, but it's not got a lot of medical emergencies that you must go into hospital in the middle of the night for. Another big part of being a medical oncologist is working closely with other healthcare workers, including the other doctors that are involved with the care of the cancer patient. So I mentioned earlier, surgical oncologists and radiation oncologists. We also work very closely with pathologists, who are the ones who really look at the slides and try to determine aspects of the tumor, which will help us in treating it. So we rely a lot on the pathologist's opinions. And we also work very closely with the radiologists because they're the ones who will give us expertise on what's happening in terms of the cancer. Is it responding to the medication we're giving them? Is it growing? And so we do have to do a lot of imaging in medical oncology, and we have to look at a lot of images to see what's happening with the cancer. So we work very closely with our radiologists. And so we have, so part of the culture of being a medical oncologist is attending these tumor board meetings, which happen regularly. So for me in my hospital, we attend them one meeting every other week for each of the sites of cancer. And at these meetings, any difficult cases we bring to the table, and then we have the opinions of the radiation oncologist, the medical oncologist, the surgeons, the pathologist, and the radiologist, and everybody's there and able to make decisions as a team in terms of what is the best treatment option for this case that you're discussing. And another component about being a medical oncologist is research involvement. So if you're working in an academic center, then chances are you are very closely working in a research setting where there may be many clinical trials, and you may actually be the principal investigator on some clinical trials. But even being a community medical oncologist, we still do have a lot of our patients being enrolled in clinical trials, either at our hospital. We currently have, I think, about 5 clinical trials running in our hospital, and we're a community hospital. But when we have a patient who has really completed all of the standard treatments that we would offer and their cancer is still growing, then we do look at other hospitals that may be in the area or maybe even further away, which may have research clinical trial opportunities where the patient can have access to drugs. because through the clinical trial. And so whether you're a community oncologist or a academic oncologist, always looking for different clinical trials for your patient is really going to be a component of your care, your clinical care. So now I have about 3 cases to discuss, and we can walk through them, and you can get an idea of really what it feels like to be a medical oncologist, how the patients present, and how we treat patients. And hopefully that will kind of give you a sense of that. So the first case is a 60-year-old female who presents with a large bump on her breast, which is red. So she goes and has a mammogram and an ultrasound, and is recommended to have a biopsy, which comes back showing invasive ductal carcinoma, which is the type of cancer that is the most common type of breast cancer. And then we look at different receptors, which are ER, PR, and HER2, and that gives us additional information on the cancer and how to treat it. At that point, she is referred to a surgeon, which is usually the first step that happens when a patient is diagnosed with a breast cancer. They're initially sent to a surgeon. But the surgeon sees that the cancer is quite large and it looks quite inflamed. And so in these particular cases, they would refer the patient back to, the patient has not met a medical oncologist yet, but the surgeon would refer them to a medical oncologist to see whether they could be given some chemotherapy to shrink the cancer so that they may be able to do a more successful surgery on them. So the medical oncologist recommends that the patient have neoadjuvant chemotherapy. So neoadjuvant chemotherapy is chemotherapy that's given prior to surgery. And so the patient completes that and the cancer shrinks. And then as it's shrinking, the medical oncologist monitors it and is able to see that it's shrinking, and then they know that the chemotherapy is indeed working. So they do complete the full course. And after that, the patient goes back to the surgeon and goes for surgery to have whatever the surgeon recommends, either a mastectomy to have the breast removed or a lumpectomy to have just the lump removed. And she was only found to have half a centimeter left of the cancer, whereas initially it was several centimeters big, so it did shrink. The medical oncologist's job at this point would be to see the patient after the surgery and say that that because they had a lumpectomy, that they now need to have an opinion from a radiation oncologist who will be recommending some radiation to the breast. And the reason would be to help prevent the cancer from coming back in case any cells had escaped and could be hanging around in the breast, any cancer cells. So the patient would then have radiation done with a radiation oncologist, which would be about 5 weeks of daily radiation. And then you would also recommend to the patient that they take an anti-estrogen treatment because their cancer was estrogen positive, which was the ER positive. And this would further reduce her risk of having breast cancer coming back. So as a medical oncologist, you are often the one facilitating the referral to the radiation doctor, and then you're also doing more of the long-term follow-up with this patient. So you would give them any advice as to any treatments that can further reduce their cancer from coming back, which in this case would be a pill to take for 5 years. And you would also then be the one to do their surveillance, which is making sure that we can sort of detect any new cancers very early. So you would do an annual mammogram and you would do breast examination. As well, as a medical oncologist, a big interest of mine is to really talk about lifestyle modifications and how they can also help further reduce the chances of the cancer from coming back. So with breast cancer, we know that having a low-fat diet, we know that exercise, we know that certain changes in their diet, including following more of a Mediterranean diet, we know that these are lifestyle changes that can actually reduce the risk of the breast cancer from returning. And so it's really important to counsel patients on those things. The second case is a 70-year-old Caucasian male who has a history of hypertension, high blood pressure, and gout, and is on these 3 medications. He has a significant smoking history. And he went to his doctor, his family doctor, for a routine checkup. And the doctor found that when he listened to his lungs, he had a wheezing in his right lung. And so he ordered a chest x-ray. The chest x-ray showed an abnormality in his right lung. And the patient was otherwise feeling well. But due to the abnormality, he was then referred to have a CT scan, which did show in his right lung he had a 3.6 centimeter mass, and he also had lymph node involvement. So he had that lymph nodes that looked enlarged, I should say. And so he went on to have a biopsy of this right upper lobe mass, and he was found to have an adenocarcinoma, which is the most common type of lung cancer. And these are some of the details of the pathology, the TTF1 and the napsin A+, EGFR, ELK, and PDL1. And these are also things that we use to help guide us in terms of the best treatment for the patient. And this is a CT scan, which shows the tumor in his right upper lobe. And then, so at this point, when we find this, we do need to complete staging for this patient. So we would have to do, so often it's the medical oncologist, once the tissue determines, the pathologist determines from the tissue that it is indeed a cancer, then they're often referred to medical oncologists, such as myself. And then we would complete all of the staging scans. So we would do a bone scan to make sure there's no cancer gone to the bone. We would look at the head with CT or an MRI, and then we would do a PET scan as well. And then we would also refer them to a thoracic surgeon for a mediastinoscopy, which is taking a little scope and looking in the mediastinum for any lymph node involvement. So these are images from the PET scan, which did light up that there was the right upper lobe mass, as well as a subcarinal lymph node also did show up. So as is often customary, these patients' cases are reviewed at the MCC, which is the multidisciplinary case conference. And here, the medical oncologist and the radiation oncologist came together and said that they recommended doing a combination of chemotherapy and radiation in this patient to try to cure them, because they were not able to have surgery. It was not, the surgeons looked at it and said that it was not amenable to surgery. So the patient did that, the chemo and radiation. And after that, they were enrolled into a clinical trial, which was available. And it was available for these types of patients. So these are non-surgically resectable stage 3 lung cancer patients. And once the patient is enrolled into the clinical trial, they are randomized. And so as a oncologist, you know what you want them to get, what drug you want them to get. But unfortunately, sometimes you are not able to know, because they are randomized and they are blinded. So you can enroll them in the clinical trial and you're not really sure, are they going to get placebo or are they going to get the treatment arm? So the patient completes this for 1 year, this treatment every 2 weeks. And it was very well tolerated. And actually the patient continues to do well, and there has been no signs of cancer coming back at all. So that has been a good case of curing that patient. Now, my third case is a 93-year-old male, and I wanted to sort of highlight a different type of medical oncology scenario. A 93-year-old male who is admitted to the hospital because he has falls, and he's found to be anemic. So his hemoglobin's very low. So while he's admitted, anyone who is over 70 and has a new anemia, we really do think about colon cancer as one of the top reasons for why they may have anemia, and for one of the things that we need to look for immediately. So we do colonoscopies on all of these patients. So this patient was found to have a locally advanced cancer, And therefore, he then had to complete staging to understand, has it metastasized or has it spread? And it unfortunately did show that it metastasized to the lung and the liver. At that point, he's not considered to be a surgical candidate anymore. He's had stage 4 cancer. And so the options for this patient really are to have chemotherapy. And the patient, in order to have chemotherapy, a patient must have a certain performance status. A performance status is something that medical oncologists talk about a lot because it gives us an indication of how a patient is performing at home in terms of their day-to-day activities. And it also indicates whether they may be strong enough for chemo or will they be too weak for chemotherapy, and therefore it would actually be dangerous to administer chemotherapy to these patients. So one of the things we do look for many of our cases, not all, but many, is that patients are strong enough to be at least at home and not in a hospital. And so that was a requirement, that he must go home strong enough. But he discussed he had a discussion with his family, and he was 93, and he felt that he did not really wish to go through chemotherapy once he understood what it would entail. And he felt that he had sort of lived a complete life, and that he was ready to prepare for the end of his life, and really wished to be kept comfortable and not suffer, rather than have any specific treatment of the cancer. At this point, the palliative care team is introduced, and the palliative care team is the team that really deals with pain, symptoms, and also end of life. And so they're introduced to the patient, and there's usually a palliative care physician along with nurses, and really a focus on talking about end of life, talking about where is the best place for somebody at end of life to be. And for this particular patient, the decision was made to go to a hospice for end of life care. So some advice for pre-meds. So I think that as pre-meds, you are required to take a lot of classes, but there's also some leeway to take additional classes that are not required and that you can choose on your own. And my advice, and what I did, and I think it served me well, was to take classes that interested me. And to be honest, not all of them were directly medical related. I did some Shakespeare, I did some other English classes. I took a religious studies course, and I really enjoyed them. And so I think that was, for me, part of what made undergrad interesting for me. And I'd also recommend that you make sure you have an outlet for having fun and for creative self-expression. So a lot of times, when you're focused on trying to get into medical school, it feels like creativity is really not something to prioritize. But I think that we all have a creative side, and that if we're able to have some fun and let our creative side come out, then it allows us to have fun with the things that we're doing, and even have more fun with the more mundane classes that we have to take to get into medical school. I would recommend questioning yourself at all times, questioning at this point, if you're trying to get into medical school, why it is that you want to go into medicine. Make sure that it's something that feels good. Sometimes we think that we like the idea of having a particular career. For example, I really liked the idea of being an academic medical oncologist, but I didn't really enjoy it while I was doing it. And so I think it's important to constantly be questioning, why am I doing this? And does it feel like the right thing that is the right fit for me? And then I think that being curious about the different areas of medicine and constantly trying to keep an open mind, and just, to some extent, going with the flow and see what you really enjoy and following that, and keeping an open mind about it. So that's really what I would recommend. And so now I'd be happy to answer any questions at all.
Thank you, Dr. Punam. That was very informative. I actually have a question for case number 2. You mentioned how the patient was going through a randomized treatment.
Yes.
And I was wondering how long the treatment usually lasts. You said around a year. So I was thinking, like, is it just one medication throughout that time?
Yeah, so that's a great question. So in this particular clinical trial, it was called the Pacific Clinical Trial, and it involved, the way that it worked was that it wanted, the question it was asking was for stage 3 cancer patients who are not candidates for surgery. These are patients who usually undergo chemotherapy and radiation to try to aim for that cure. And the question that this clinical trial wanted to know was, if we give them a treatment called durvalumab, that was the name of the drug, and this particular drug happens to be given intravenously every 2 weeks for a total of 1 year. Okay, and so in this particular trial, that's how it was given, and then after that completion of the year, then patients were just followed. So there was 2 arms in the trial. There was a randomization which happened through the clinical trials department, where patients have to go into one of the groups, and then one group did have the placebo every 2 weeks as well for the year. And so all clinical trials are different. There can be some trials that are looking, for example, even looking at durvalumab, which is the drug used in the Pacific trial. There's trials which are looking at it for either a shorter duration or a longer duration. So really, the way that the studies work are all unique.
I have a question from Miriam on the chat box. She says, for the second case, was the placebo group the standard cancer treatment at the time?
Yes, that's true. Yeah, that's correct. So at the time, the completing chemotherapy and radiation would have been the end of the treatment. So the placebo is essentially normal saline, which is nothing, which having nothing after completing chemo and radiation was the standard, yes.
And another question from Yuna. Did you always want to go to medicine? If not, what were other fields or careers you considered?
That's a great question. I think that for me, in my case, I think because I had my father who was a big influence, and he was like pretty much a role model for me. Because of that, I think I was influenced to go into medicine at a very early age. But when I was in undergrad, I questioned it more than I ever had even prior to that. So I did question it. I wanted, when you go to undergrad and you move away from home and your eyes kind of, you are opened up to a whole new reality that you didn't know existed. So I took like I mentioned, I took some courses that I really loved. I loved literature and English and philosophy. And so I took some courses in that. So perhaps I may have pursued a more academic career in something in sort of like an English literature. But if you were to just ask me, like, what would I be if I was not a physician or a doctor, my answer would be, I think I'd be an architect, because I really do love, I love math, and I also love designing. So yeah, that's probably what I would be.
I have another question from Angel. He says, I'm currently considering cancer genetics, but I'm not sure if I should pursue genetics or oncology. from the medical oncology perspective, what advice would you possibly have for this specific specialization?
So I think that cancer genetics, it's interesting. There is definitely a patient component to doing genetics, and it's a different patient connection that you would have or interaction that you would have as a medical oncologist. So as a medical oncologist, you are really the one that they come to once they're diagnosed with cancer, and you are with them along that journey, like through thick and through thin. And there's very happy stories where you're able to tell somebody that there's a 95% chance that they're gonna, live the rest of their life with no cancer coming back. But then there's also a lot of cases where you are with them till the end of their life and you're holding their hand through that journey. So it's a very unique type of a role that you do end up playing in your patients' lives. I think that my understanding of genetics is that they may follow patients as well, but they're really more targeted towards looking at sort of if they have any genetic mutations and what their risks may be, and screening for that and counseling on that. So I think in that way, the clinical aspect is unique. So my advice would be to get exposure to both areas and see which one just fits you better, which one are you having more fun doing, which one interests you more, which one do you see yourself doing.
Thank you, Doctor. Karina asks, do you see brain cancer patient often? Specifically patients with glioblastoma, and if you've seen anyone survive with it.
Sorry, could you ask me the first part of the question again?
Do you see brain cancer patient often?
Okay, so in my particular hospital, we don't see, we do refer the glioblastomas and other brain cancers to a tertiary site where they have a more sort of specified unit, you could call it, or clinic, where the surgeons and the radiation oncologists and medical oncologists are all working together just specifically for brain cancers. So I do not myself see them. I have experience during my residency training working in CNS oncology, but it's not, these are not the patients that I usually see in my own practice.
And I have one final question. I had an interest in your teamwork when you are discussing the case with the tumor board meeting. If your opinion is different from the other specialist, how do you decide which treatment to provide for the patient?
So that's a great question, and that is certainly something that happens not too infrequently, where there may be disagreements. I think that that's why it's so important to have these meetings, because then you can feel like your patients are being treated in a way that has been discussed, and it's not really biased towards one particular physician's skewed or perhaps biased opinions on how to manage something, but rather the goal is really to try to base treatment on evidence. And so when we're having these discussions, a lot of times we're actually talking about different studies where patients such as the one that we are discussing, how do they do, and why it is that we would recommend what we do recommend. And so these discussions are very informative. I love attending them because I'm constantly being taught new data that's come out, new studies that have come out from my colleagues' areas, such like the radiation and the surgery. And so I think that it's not so much an opinion in terms of like I like to do this and someone else likes to do that, and so we want to do it our way. But I think that the discussion really becomes about, well, what the best option for the patient, and we make a case on why we think that our recommendation is the best. And the goal at the end of the MCC is to get enough opinions from everybody in the room to come up with a consensus. And so usually there is a consensus made by the end of the discussion.
I know, Doctor, that your time is very valuable. We have 2 more questions if you have.
Sure. Yeah, no problem.
So Heidi says, I've often heard that oncology is a hard field, or a field that can be fairly emotional. Do you ever find yourself becoming discouraged working in a particular field? Or are you more driven and encouraged by potentially creating a treatment plan that could help someone beat cancer?
Well, that's a really good question and a very good point. And I am asked that question constantly, and even by my own patients. And they say, this must be really hard for you. And I think that's the thing about finding the right fit for you in medicine. It has to be something that feels good, right? So it's hard. If you go into oncology thinking that you want to really cure everybody of their cancer, then it's going to be a really big disappointment, and it's going to be very hard emotionally. It was interesting because during my training, there was a study that had come out or something about palliative care physicians. It was, I think, a survey done with palliative care physicians, and I found that they were the happiest physicians, really, and they're the ones dealing with death. And that was very interesting because it's really how you interact with your patients and what your overall goals are. And if you're able to meet your goals, that's when you get job satisfaction, right? So if a lot of our patients die, we see some very, very sad cases. And I think that what's fulfilling is knowing that you were there with your patients during that journey in the capacity that you were able to. And sometimes that really is just the end of life care. And you're not able to help them live longer, but you're able to help them die in a way that is peaceful, they're not in pain. You're able to have discussions with family that are meaningful. And so that is quite fulfilling for me. I really do enjoy and value that aspect of my job. I think that there's definitely times where it can be emotional. So at times you come home and you feel sad. I'm lucky because I do have some physicians in my life. My father, my husband's also a physician. And so we are sometimes able to just share stories of what we've been through, and that does help. And so there is that, but that's what makes it human. And that's what I think that it's important to care. And once you stop caring is when you have to start doing something else. So I think that for the right person, it can be a very fulfilling choice in terms of medicine.
And one last question from Jasmine. Sure. She's asking, what made you interested in medical oncology, and did you consider other specialties? And also how you deal or cope with getting attached to patients in loss.
Yeah. So I didn't always know about medical oncology. I went into internal medicine, and I was somewhat open to different areas of within internal medicine. I just found that I was always drawn to my rotations where I was doing oncology, and really I had a very open mind, and I just found that I was enjoying my experience in oncology, and really that was why I chose it. And I think, I'll be completely honest. I knew that I wanted to have a career where I had a pretty decent balance in terms of work and life, because I knew that I wanted to have a family, and I knew that it was possible to have relatively balanced life. Relatively as in within medicine, right? Balanced life. And for me, that made, and I do feel like I have that. And I think that was another component for why I chose to do community oncology. I felt that I had a better work-life balance. And as a result of having a better work-life balance, I felt I was a better oncologist, right? And so I have 4 children now. I had just had twins 9 months ago, and I also have 2 other very young children. So it ended up being a really good match for me to be a community oncologist and balance my life with my children at home as well. So that was another big part of why I ended up choosing medical oncology when I thought about that. And then how to deal with loss. I think that well, it's funny because I didn't even mean to do this, but I just realized that my Instagram name is here. It's the Mindful Mama, and I just recently opened that account. It's not that been around for that long. It's just several months. But the reason I chose that name is because I got introduced to mindfulness about almost 10 years ago, and it really changed my life. And it really helped me learn to really live in the moment. And I took a 6-week course. It was an 8-week course I took on mindfulness meditation. And I think that for me, honestly, that's been a really huge coping strategy for me, because when you learn to really live in the moment, you really are able to be present with your patients. When you're talking to them, you're there with them. You're there, you're engaged, and you're really nowhere else. You're very mindful and present. And then you're able to sort of go through the emotional experiences with your patients. Sometimes I cry with my patients. Not a lot, but I do sometimes. And but the thing about learning to be more mindful is that you also learn to let go better than you could have before. For me, better than I could have before. And so again, when you come home, you learn to be more mindful in your home, right? And you learn to be there with your children and sort of be focused on what it is that you're with right now. So to answer your question, I think mindfulness is being mindful and learning about mindfulness is a huge way, a huge benefit in terms of coping with loss in my practice, and then also just with coping with issues in life. So yes, go mindfulness. It's like you planted that question in there.
Thank you so much, Dr. Punam, for taking time out of your busy schedule.
Yeah, no problem. My pleasure. I hope it was helpful. And you can, if you like, you can find me on Instagram and you can send me any messages. And I'm always happy to share my experiences to help anyone.
Mm-hmm. And everyone's saying thank you on the chat box.
Okay, great.
Yeah, have a nice day.
Thank you. You too. Take care.
Mm-hmm.
Bye.
And for those of you currently attending, make sure to verify your attendance. We will post the link very soon. Oh, it's posted, I believe. So make sure to verify your attendance. And our next event is happening on April 16 with Dr. Vanessa Richardson. She's a physician in dermatology, so stay tuned for that. And again, thank you very much.